Hi everyone, it's Jamie Gomes. The title of this presentation is Medication Safety Technology, Preparation and Dispensing. Here are the disclosures from the presenters of this module for your reference. The learning objectives for this presentation we do have some key abbreviations to bring to your attention that we'll use throughout the presentation. So we'll start off with a self-assessment question to consider throughout the presentation, and we'll come back to it at the end. So it's which of the following is not considered a safety improvement of dispensing technology? A, barcoding. B, interfacing with the EHR or pharmacy system. C, maintenance of medication and clinical information. Or D, alerting capabilities. We'll be talking about a number of technologies that are used throughout the preparation and dispensing processes. So workflow technologies, barcode scanning, repackagers, robots, medication tracking, and ADCs. But I will say these technologies tend to be very disjointed from one another. They're very specific to certain types of medications and workflows. So it's kind of just all separated from one another. So dispensing errors. Dispensing is a complex process which includes many different preparations of medication. Dispensing technologies can aid in the workflow, but also help in decreasing dispensing errors. Dispensing error is defined as a discrepancy between the prescribed medication and the actual medication dispensed by the pharmacy. They can be prevented, so meaning it's caught by either a technician or a pharmacist before leaving the pharmacy, or unprevented, it actually makes it to the unit for potential administration. There are a number of factors that might contribute to dispensing errors, so high workload, low staff numbers, mix-up of look-alike, sound-alike drugs is a very common one, and there are so many of those. You can work on separating stock, but it can still lead to dispensing errors. So technology has really helped with those. And also lack of staff knowledge and experience. So there's a number of different types of dispensing considerations that can be based on the type of drug or even maybe drug specific. Here are some examples of errors that can occur in the non-sterile medication dispensing errors. So, of course, dispensing the incorrect medication and dose. So that could be incorrect drug or concentration, or incorrect strength or release mechanism, the incorrect combination of tablets or capsules or cups, the incorrect volume drawn into the syringe, or the incorrect label placed on the final container. I also included some thoughts about compounding and potential errors with extemporaneous compounding. The picture to the right shows you the pick area for oral medications. You can see there could be a number of different strengths and also a combination of brand names or drug release mechanisms even for the same drug. So you can see how it could be very easy to pick the wrong one even from these small little inserts that we have drugs stored in. In the sterile area, there are some very similar mix-ups that can occur, like incorrect medication and dose, which is very similar to the non-sterile production areas. Compounding errors also can occur with medication and diluent mix-ups. The picture I included here is of look-alike vials of verapamil and naloxone. The text doesn't even necessarily look the same, but the colors on the label, the cap, and the same vial size can contribute to an error occurring. In these cases, we try and buy from different manufacturers to help differentiate, but it can be very difficult to maintain that over a broad scope of vials that a pharmacy can carry, especially during times of drug shortages. Also, in a sterile environment, you can have sterility errors with the potential that critical sites are contaminated, as listed on the slide. Double-check processes have historically been used to catch a lot of these incorrect medication and dosing errors, but human errors are always a possibility. It's important to have policies and procedures to help decrease these errors, but including technologies are very helpful to support the effort. So the first piece of technology I want to talk about is barcode scanning. It's a crucial step that's integrated into many different health information technology. It's a helpful confirmation step in stocking of medication inventory and compounding and repackaging and overall dispensing. However, it does have limitations. When we think about the products we buy, there could be a lack of barcode, so may introduce the need for a pharmacy to add a barcode, which also introduces a manual human step that can introduce error. There could be similar barcodes, so a scanner may only read a certain number of characters, so products with similar NDCs may scan and pass, even though the size of the product is different. So this happens a lot with topical products in different package sizes. I've seen it with pediatric glycerin suppositories versus adult glycerin suppositories. Also, products coming out can have very unique barcodes that can be difficult for technology to keep track of. So certain products may introduce new information like lot and expiration into the barcode. So depending on the upkeep needed in the technology, this can keep upkeep issues when getting a new stock. There's also this reliance on barcode scanning that occurs. So with certain technology, you might not be scanning the barcode for each item, maybe just for one of a bunch of drugs, which doesn't necessarily confirm the accuracy of every individual unit. So very important to maintain appropriate stocking procedures. And lastly, also multiple barcodes can be an issue. So what if multiple barcodes are on a package? This usually occurs because of different technology adding barcodes. It might be difficult to determine what barcode is the right barcode to scan. So even our barcode scanning procedures have become quite complicated over time. Next is repackagers. So unfortunately, like I mentioned before, each piece of this dispensing technology can be very segregated from each other and require individual upkeep and workflows. So repackagers aid in dispensing unit dose products. They can be used for both solid and liquid oral dosage forms. And they do have the potential for you to scan the source product prior to repackaging, so that barcode step. Some advantage of unit dose dispensing include reduction in medication errors, reduction in the size of drug inventories, inpatient care areas, and adaptability to technology. But there are a number of challenges, including ensuring the correct drug is prepared with the correct labels. It can be dependent on other technologies, so the need to create custom NDCs or barcodes for certain package sizes, the need to align terminology and drug names across the medication use process has also come up. So making sure that the EHR and the repackagers are using the same terminology. On the right-hand side, I included a picture of what a repackaged label can look like. It could be quite small, so you could have a limited number of characters to really describe what the drug is that you're dispensing. There's also restrictions on what can go in the packager as far as volumes and sizes, and also it still makes the dispensing process a pick process. You'll repackage the med, it will still go on the shelves for a manual dispense. Robots, as we'll discuss on a future slide, can help with that and select patient-specific dispensing, but it's unlikely to be able to completely eliminate pick errors. Carousel dispensing technology can also aid with the pick process. It does require barcode scanning and provides direction to find the correct medication, interfaces with the EHR and even ADCs, and helps keep look-alike packages and look-alike sound-alike medications separate. However, a study conducted in 2007 by Oswald and colleagues did not find a difference in dispensing errors post-carousel implementation. It's possible that not all the dispensing errors were caught in the pre-implementation data, but it does call to light other considerations regarding carousel dispensing technology. So errors can occur attributed to restocking. Overflow of medication bins can cause one medication to flow into the bin right next door. And medications pulled from the carousel may not immediately be put in a dispensing bag. So again, technology can aid a process, but policies and procedures around these non-technology-based steps must be created and adhered to. Overall, there has been limited literature exploring the potential to prevent medication events with carousel technology. Robots are also available in the non-sterile and sterile environments. First, we'll talk about the non-sterile. So they come in many different shapes and sizes, and some may function as a repackager as well. They do have a number of safety features, including barcode scanning, patient-specific medication dispensing. So in other words, it's eliminating those pick errors when it picks for a specific patient. They can interface with electronic health records, and it is a safer way to segregate look-alike, sound-alike medications. However, the robots do have a number of limitations. Similar to repackagers, space can be limited on the label, so close consideration and upkeep may be needed to align the names with the EHR. Robots can malfunction, leading to the wrong medication being dispensed or an incorrect number of tablets or even a mix of medications. They also require a consistent NDC be needed, which can be an issue in drug shortages or manufacturer discontinuations. They may also compete with other technologies in the EHR, meaning other technologies may rely on similar fields in the medication order to integrate. It may be possible to align the multiple technologies, but as more and more implemented, this may become an issue. And also just of what you can actually stock in the robots. So staying away from stocking hazardous drugs or common medications that could cause allergies like beta-lactam antibiotics. Those may not be able to be included. And also size limitations of the medications. There's a lot of planning and coordination that goes into using these robots, so you may or may not be able to use it right off the bat after a drug is added to the formulary. As far as sterile robots, they also provide a number of safety improvements. So they provide an ISO Class 5 compounding environment. They require no human intervention once the compounding begins. Uses UV light sterilization of vial stoppers and bag ports. They introduce barcode verification of the source vials and bags. Records images of the compounding products as part of an audit trail. They can be able to interface with the pharmacy system or EHR with careful consideration. Patient-specific labels, so they can do patient-specific doses if you have them set up that way. And they're also more accurate in drawing up medications as they use specific gravity weight before and after every fluid transfer. However, there are limitations, including challenges with the interface to the EHR and maintenance of medication information. They also require consistent NDCs, so you may run into issues rendering certain NDCs unusable. Sometimes we run into issues with more mechanical issues, like the robot can't grip a vial, or issues actually manipulating the vial. Overall, IV robots still require a lot of time from the staff to fully maintain and stock the inventory, even though once compounding begins, no human intervention is required. Another piece of technology that we see in the IV room more frequently is workflow technologies. They aid in reducing IV compounding and dispensing errors, and now they're being more and more considered to be used for non-sterile preparations as well. Workflow technologies do have a number of advantages. They include barcode verification of all components and help to standardize the IV compounding process. They streamline IV room workflow, including reducing interruptions and eliminating the need for checking an empty syringe when using the pullback method for checking. They improve dose status tracking throughout the pharmacy, reducing rework and aiding to get the drug to the patient on time. They help reduce waste, and they display and store key preparation details, which can be very helpful when evaluating medication safety events or other issues like recalls. This is an example of the directions for an IV prep, which includes letting the tech know exactly how much to draw up and what information and images need to be captured. Additionally, more guidance can be added as like auxiliary instructions for the preparation staff versus keeping something manual like a recipe or compounding book. So there are also challenges with workflow technologies, including maintaining the clinical information and medication information like barcodes. Some medication also is unable to be integrated with the EHR and the workflow technology, which may require escalation through the technology's vendor. Overrides are also a common request. We try to minimize them as much as possible. Sometimes this creates workarounds, which we try to eliminate. I did run into an issue not too long ago of trying to force a med to go through the workflow technology, which actually led to double the dose almost being dispensed. It showed up with the correct dose of the med, but asked the tech to draw up double the volume than what was needed. Additionally, there may be additional time needed to prepare the dose. This is perceived additional time as staff gets accustomed to the technology. They'll get faster at using it. After the drug is prepared and ready to be dispensed to the unit, medication tracking systems can come in handy. It's not something people typically think as a medication safety technology, but it definitely adds in helping the time to medication administration. Medication tracking systems aid mostly in operational processes and helping with transparency to determine where the drug is located. But there are perceived safety improvements, like I mentioned, like ensuring the appropriate time to administration and also identifying distribution issues. These technologies are very helpful in the follow-up of medication events and improvements in drug distribution. The tracking is specific to patient information, order number, dose number. So I put a chart on the bottom, which is an example of what tracking could look like. Ideally, you notice in the location section, we would say exactly like the patient bin or type of storage area that the med was delivered to. The last piece of dispensing technology we'll talk about is automated dispensing cabinets. They offer a number of safety improvements, including that they interface with the EHR, they have alerting capabilities, barcode scanning, medication-specific cubicles, patient-specific cubicles, and they streamline dispensing and time to administration for the nurses. They do have a number of limitations. So space being a big one, just trying to put all the meds that are requested on the floor can be difficult. Managing supply pars and expired supplies, stocking errors. So think back to the barcode discussion where you may only need to scan one unit to refill an ADC, but that means you could still have errors in other items that are stocked because you're not scanning each one of the units that you're adding to that specific cubicle. Matrix drawers also are wide open and allow for any drug in that drawer to be picked technically. Stockouts may cause a delay in medication administration, and overrides may lead to potential errors. So overrides may be needed due to the system being on override due to malfunctioning or due to emergency situations, but it's important to set standards for what meds should be allowed to be overwritten. Other limitations include selecting the wrong medication and maintenance, whether that's the software or just the medication list of what's available. There was a fatal medication error in 2017 between Versed and vecuronium due to a selection error in an ADC. After that event, a number of recommendations were released by the ISMP, some of which address the limitations we discussed on the previous slide, especially the first two recommendations of optimizing using profiled ADCs, so the meds are specific to a patient and verified by the pharmacy, and manage override lists. This can be confusing just managing within the ADC system, and it's not very transparent to everyone, so I recommend creation of a hospital policy for transparency. There's also blocking staff from loading inappropriate medications, utilize warnings during medication removal if applicable, witness override medication removal, allow simultaneous searching by brand and generic names, support distraction-free ADC medication removal, limit access, and affix warnings to ADC pockets. Both ASHP and ISMP have guidelines for safe use of ADCs. The ASHP guidelines discuss the planning and structure of implementation, education, and maintenance of ADCs. They also talk about safe storage and distribution, so ensuring a sufficient quantity, making sure the location and environment is appropriate, and having the appropriate infectious control policies and procedures. They also recommend to minimize overrides and review data to continue to improve. Also consider that ADCs allow for single unit or unit dose packages to be utilized, so ideally those medications should be in a ready to administer form and only available at the time of administration. ASHP also includes a safety check plan for safety monitoring and storage of inventory to be determined prior to implementation through a partnership between pharmacy and nursing. So some of the recommendations for the safety check plan are listed on these slides, like identifying potential sources of medication errors, use of clinical alerts, and down to even the transportation of medications from the pharmacy to the ADC and then from the ADC to the patient. The ISMP guidelines for the safe use of ADCs also include 9 core safety processes, and some are very much aligned with what was in ASHP's guidelines. So provide ideal environment conditions, so consider what types of orders will come from the ADC. Will it be first doses, PRNs, controlled substances, all doses? It also talks about things such as the environment, lighting, location, space, making sure there's MAR accessibility near the ADC. It notes to establish an ADC security system or system security, so make sure you're granting only appropriate access, use blind counts for controlled substances, and create procedures to follow up on discrepancies. Also provide profiled ADCs and monitor system overrides, which we talked a lot about, of making sure that the drug orders can be verified by pharmacy for a specific patient to avoid overrides that can lead to potential errors. Ensure appropriate ADC configuration and functionality, so maximize secure storage configurations like cubicles and minimize the use of matrix stores whenever possible. Optimize ADC inventory, so utilizing patient-specific or unit dose containers. Ensure rescue agents and antidotes are available, and create appropriate PAR levels for the mins and maxes of what you're keeping stock of. Create safe ADC stocking and return processes. So having a process for double checking refills and also utilizing barcode scanning. display important patient and drug information, create procedures for withdrawal and transfer of medication to the bedside, and also provide staff education and competency validation. So we'll go back to the self-assessment question. So which of the following is not considered a safety improvement of dispensing technology? Is it A, barcoding, B, interfacing with the EHR pharmacy system, C, maintenance of medication or clinical information, or D, alerting capabilities? The answer is C, maintenance of medication and clinical information. So while dispensing technology has a number of safety improvements like barcoding, interfacing with the EHR, and alerting capabilities, maintenance of medication and clinical information is a task that must be completed so that the technology functions appropriately. So in conclusion, technologies that support the medication preparation and dispensing processes are very segmented in interface, implementation, and maintenance. Barcode scanning is a helpful tool which is incorporated into many of the preparation and dispensing technologies. Robots for both non-sterile and sterile production aid to mitigate some of the most common causes of dispensing errors. And automated dispensing cabinets have advanced features to improve the storage and distribution of medications, but take significant planning and monitoring to identify sources of potential medication errors. And with that, thank you for your time and participation.